My name is Dr. Sritish. I am working as a specialist in infectious diseases in Communicable Disease Center. Today we have this workshop related to World Tuberculosis Day. I hope I'm audible to everyone. Okay, thank you. I can
Yes,
see the
doctor. Yeah,
thumbs.
we can hear him.
Thank you very much. Just before we start, I would like to inform everybody that like for the CPD points, you'll be sharing an evaluation form at the end of the talk. You just have to fill the evaluation form and the CPD points will be recorded and sent directly to DHP. So basically this talk I have tried to make it very simple and basic because we have people from all kinds of healthcare departments joining us. It's not just intended for physicians or nurses, it's for everybody, just to have a basic orientation about World Tuberculosis Day. If at any point, if you would like to raise any concern or questions, or if the voice is breaking, or if the slides are not visible, just you can let me know. I have a disclosure statement that this presentation complies with MOHP DHP accreditation standards, and there are no conflicts of interest, and there is no plagiarism, and the content is balanced and free of bias, either commercial or non-commercial. So this is the poster by World Health Organization for World Tuberculosis Day 2025. And the theme for World Tuberculosis Day 2025, it says, yes, we can end TB, commit, invest, and deliver. So what is actually World TB Day? So World TB Day is observed in memory of a German physician, German microbiologist, whom everybody will be knowing. His name is Dr. Robert Koch. It was on Friday, 24th March 1882, that he identified this bacterium called Mycobacterium tuberculosis and announced that this disease called tuberculosis is caused by this bacterium. So that is why every year we celebrate or observe March 24th as World Tuberculosis Day. So on for every year, the World Health Organization releases problem statement, which actually represents the situation of TB until 2 years before that year. So what World Health Organization says for 2025 is that 79 million lives have been saved since 2000 by global efforts to end tuberculosis. At the same time, 10.8 million people fell ill with tuberculosis in 2023, and 1.25 million people died of tuberculosis in 2023. Just to have an overview, tuberculosis, it's an infectious disease that most often affects the lungs and is caused by a certain type of bacteria. It usually spreads through the air when infected people cough, sneeze, or spit. This is a preventable and, more importantly, completely curable disease. And we have to remember that about 25%, that is about a quarter of the global population, is already infected by TB bacteria. So by that, I mean they have just been infected. Doesn't mean that all of them have symptoms of tuberculosis or they have TB disease. So in further in the talk, I will help you to distinguish clearly between what is TB infection and what is TB disease. And at the same time, only about 5 to 10% of the people who are infected with this TB bacterium will eventually develop the TB disease. That is, they develop symptoms and signs related to tuberculosis. This is only maximum up to 1 out of 10 people. So those who are infected but not yet ill, that is those who have TB infection but don't have the TB disease, cannot transmit it, which is very important. The TB disease is usually treated with antibiotics, but it can be fatal without proper treatment. This is about TB disease. In some countries, there is a vaccine called Bacillus calmette-guerin, which is BCG vaccine, which is usually given at birth to small babies or small children to prevent tuberculosis. But what we have to remember is that the BCG vaccine is not proven to not proven to prevent pulmonary tuberculosis, but it is proven effective against extrapulmonary tuberculosis, especially TB meningitis. If we come to microbiology, this bacterium, Mycobacterium tuberculosis, it is an oxygen-loving bacterium. So that is why it has a preponderance to lung tissues, especially upper lobes of the lung tissues, where there is excellent oxygenation or aeration. It has a preponderance to these areas to cause infection because it is an oxygen-loving or aerobic bacterium. It is a bacillus or rod-shaped bacterium, as you can see in the image, and it doesn't form a spore and it is non-motile. What distinguishes it from other bacterium is that its cell wall is made of mycolic acid, which can retain acid-fast stain, which makes it very difficult to be treated by the normal kind of antibiotics. It is a very slow growing organism because it takes around 3 to 8 weeks for growth on solid medium. That is why usually when we send TB culture, it's grown for at least 6 weeks before finally declaring that it is negative or positive. The Mycobacterium TB, it is, as I mentioned, slowly growing organism. To compare, the doubling time for it is 18, that is one organism to become two, it takes around 24 hours, whereas for fast growing bacterium like E. coli, it takes only 30 minutes. And it has a lipid rich envelope, which makes it resistant to many bacteria like beta-lactam antibiotics or tetracycline antibiotic. And it can grow into a long latency inside the cells. The transmission, as I said, is mainly aerial. So the it is transmitted by airborne particles, which are very small in size, which are usually less than 5 microns. And that is why we usually keep the patients when suspected with pulmonary tuberculosis on airborne precaution. The ease of transmission depends on duration and proximity of contact, as well as the number of bacteria excreted. Infection can result from even 1 to 5 bacteria entering the terminal alveoli. So to summarize, it's airborne transmission. Its majority of the TB transmission is by airborne route. But there have been few case reports where consumption of unpasteurized milk from infected cow has caused tuberculosis. And sometimes, very rarely, organ transplantation and congenital tuberculosis have also been reported. The pathogenesis of tuberculosis, about 10% of infected people, those who get the bacteria in their body, 10% of them eventually, if they have a normal immune system, they eventually go on to develop TB disease at some point in their life. But at the same time, people with HIV who are immunocompromised people, they have very, very high risk of developing active tuberculosis or TB disease when they have TB infection or latent TB. For HIV infected people, this is almost 10% every year. Compared to people with normal immune system, they have a lifetime risk of 10% developing active TB. Also, there are certain other medical conditions which increase the risk of developing TB disease when they are infected. So these diseases include chronic renal failure, diabetes mellitus, silicosis, leukemia or lymphoma, carcinomas of head and neck or lungs, people who have weight loss of more than 10% of ideal body weight, and those who have gastrectomy or jejuno-ileal bypass. But the highest risk among all the risk factors are those infected with HIV. Diagnosis of tuberculosis. So as I told you, the most important at basic level is to understand what is latent tuberculosis or TB infection and what is active tuberculosis or TB disease. These are two different things. So latent tuberculosis or TB infection is when somebody goes near a TB infected person, and the patient who has a TB disease, who has an active tuberculosis in their lungs, they are coughing, and the bacteria comes out of their lungs into the airway and enters inside another one's body. So the bacteria enters through the lungs, and usually if the patient's immune system is good, the bacteria goes into a latent phase either in the lungs or in the lymph nodes or sometimes in other organs. So this is called latent TB. This means that the patient is infected by the bacteria, but as of now they don't have any symptoms or they don't have any signs. Even radiological imaging is normal for this person, and it doesn't show any features of active, like any features that the TB bacterium is dividing actively. So basically in such patients, they have a normal chest X-ray. They might have small scarring related to the initial TB infection, like there might be small nodules, small dots or spots somewhere in the lungs, or small lymph nodes somewhere in the chest X-ray. But altogether, if we take majority of the patients, they have normal chest X-ray. And usually they don't have symptoms like cough or sputum production or fever. The only thing that can distinguish TB infection from a normal person is the positive quantiferon test or positive tuberculin skin test. At the same time, for active tuberculosis is when this primary TB infection, if the patient's immune system is weak, the primary TB infection itself the TB bacterium might start dividing actively and cause signs and symptoms of tuberculosis, or the TB might remain latent for certain period, and when the patient gets a weakened immunity or there is some kind of a stress, the TB bacterium reactivates and causes signs and symptoms. So usually these people, based on where the TB bacterium is actively dividing, they have signs and symptoms related to that. Most commonly it is the lungs. So the most common symptoms are cough, sputum production, sometimes blood in the sputum, which is called hemoptysis. At the same time, they can have general symptoms like fever, night sweats, weight loss. Sometimes the TB affects the backbone or vertebral column, so patients might come with long-term back pain. If it is affecting the brain, they might present with symptoms of meningitis. If it is presenting abdomen, they might present with abdominal pain and weight loss. So literally, this TB bacterium can infect any organ in your body. So the symptoms might pertain to which organ is affected. So in most commonly, these patients present with abnormal chest X-ray, and these patients also will have quantiferon positive test or positive tuberculin skin test. So this, if you hear that somebody has a positive quantiferon alone, it doesn't mean anything. It can be latent TB, that is just TB infection without any symptom, or it can be active TB disease, but the patient needs an evaluation to identify whether they have an active TB or latent TB. So usual signs and symptoms, as I mentioned, fever, night sweats, cough, hemoptysis. If it is affecting the pleural tissue, they might have pleurisy, they might have weight loss and loss of appetite. They might present with fatigue, which are all quite non-specific. So this is what I mentioned. Usually when somebody with TB disease in their lungs. So these are the people who are actively spreading TB, who have actively dividing bacteria in their lungs. If they have an active disease in their other tissues like skin or vertebral column or stomach or brain, without having actively dividing bacteria in their lungs, then they are unlikely to spread the disease to other people. So the people who have to be isolated are those who have active TB bacterium in their lungs, actively dividing TB bacterium, because they produce aerosol containing these microbes, which you can see in the image, and which goes inside through the nose of the person near them who is not protected with an N95 mask, and this can then go to pulmonary tissue, and through self inoculation it can reach other parts of the body. So active tuberculosis or TB disease. This one commonly it affects lungs or pleura, and it can affect extrapulmonary sites, as I mentioned, lymph nodes, bone or joint. Most common bone or joint is the vertebral column or spine, which is called Pott's disease. And it can even affect the genitourinary system, abdomen, pericardium, and CNS. Practically, it can involve any organ in the human body. And there is a certain condition in which the TB bacterium, it spreads rapidly to all parts of the body simultaneously through the blood. And this usually happens in people who are immunocompromised, especially HIV patients, uncontrolled diabetes, etc. In these, we can see a peculiar pattern in the lungs because simultaneously the bacteria spreads to different small lobules of the lungs, and you can see small diffuse nodules less than 2 millimeter involving almost every part of the lung. And meanwhile, these patients have dissemination of TB bacterium to other organs like lungs, liver, spleen, bone marrow, kidneys, adrenals, everything. So this is something that is an emergency and needs to be managed rapidly. So diagnosis of active TB is usually based on, there are three important investigations which we can send on any tissue from the body. So it's not just confined to sputum or lymph nodes. Any tissue from the body which we suspect is affected by tuberculosis can be sent for this investigation. So this set of investigations we should always keep in mind whenever we suspect tuberculosis of any organ. So these are mainly acid-fast bacilli smear, acid-fast bacilli or TB PCR, and TB culture. And these have different kinds of sensitivities and specificities, and the speed at which the results come out is also different. So the AFB smear or acid-fast bacilli smear, this is basically a microbiologist or a technician looking through into a sputum through a microscope to see if there is acid-fast bacilli after staining, if there is acid-fast bacilli visible through the microscope. This is operator dependent. Experienced technicians or microbiologists can easily identify acid-fast bacilli on the slides. At the same time, TB PCR is genetic material based test. It is pure entirely machine based test. So where the machine tells you if it identifies the genetic material of Mycobacterium in a sample or not. So it gives a very rapid result. But the problem of this result, it is not good to identify whether disease is cured, because even if the disease is cured, the genetic material might still be there. So the machine might falsely interpret that still the patient is having active tuberculosis. So once we start the patient on treatment, we do not do the genetic material test or the PCR test. It is only for initial diagnosis. TB culture is the actual test which says if the bacterium is actually dividing or is it active or not, because the sample is grown in culture medium for 6 weeks, and it actually can say if the bacterium is actually dividing or not. So this is the most specific test, the TB culture, but the problem is it takes long time. It may take up to 6 weeks to give a proper result. These are microbiologic tests, these three, which confirms 100% whether the TB there is TB or not. But sometimes it might be difficult to get the microbiology sample, especially in critical tissues like brain TB infection. In such cases, the diagnosis might just be based on radiographic. So this is called radiographically diagnosed TB, like chest X-ray or CT, sometimes PET scan. Sometimes if like TB can affect certain tissues like joints, so the surgeon, the orthopedician might get a synovial biopsy. So practically any sample, any tissue that is obtained from the human body can be subjected to AFB smear, TB PCR, and culture. So whenever any patient who comes to the OR, I think we have staff from the OR attending, or surgical staff. What we have to keep in mind is TB can virtually present as any kind of disease. You might think this is something else, but it might turn out as tuberculosis. Any tissue that you are taking for a biopsy, please make sure this sample is also sent for TB smear, PCR, and culture, because the once you send it for histopathology, the samples are usually put in formalin for preservation. These once you put it in formalin, the TB bacterium dies off. So this sample cannot be subjected for smear, PCR, or culture. So whenever you are taking sample, please keep one sample aside, one sample for the formalin preservative and one sample without preservative. This one without preservative has to be sent for tissue culture to the microbiology lab and to the TB lab for TB workup. So these samples which we need to identify the organism, they should not be put in formalin. This is the kind message that I want to spread to all the support staff here. So diagnosis, the experienced microbiologist can identify the organism as beaded elongated structure. And the chest X-ray findings usually in primary TB, which means the initial infection is already causing the TB disease right away. And in such cases, the TB usually when it comes through the nose or the mouth and reaches the lung, usually it reaches the lower or middle lobes because of the gravitational reasons. So the primary TB you usually find infiltrates in the lower or middle lobe, but at the same time, the reactivation happens only in tissues where there is more oxygenation. So that is why pathophysiologically the oxygenation is higher in the upper lobes. So usually reactivated TB presents as apical infiltrates or apical cavitation. In latent TB, most of the times, 80 to 90% the chest X-rays are normal, but the patient can have some scarring because of the initial primary infection, which is nodules in the hilar region or upper lobes, or they can have some pleural scarring as well. So this is an image which shows almost complete consolidation of the right upper lobe. And this is a patient who had a active pulmonary tuberculosis because of reactivation. This is CT scan image from the same patient. This is miliary TB, where you can see tiny nodules less than 2 millimeter, which is distributed all over the bilateral lung fields. So this we have already discussed, the TB-PCR, which is otherwise called nucleic acid amplification test, or NAT. There is a TB skin test, which is more or less now being replaced by quantiferon test. So this was previously used. This is a low-cost test where they inject a small amount of purified antigen from the TB bacilli, which is called PPD, purified protein derivative. And we wait for a delayed hypersensitivity reaction to this, and which is read after 72 hours after inoculation. But this the rate of false positives and false negative is high in TB skin test, and the interpretation is also, it is operator dependent. It needs an experienced person to interpret, because actually we should not measure the redness. What we measure actually is the induration. If we measure the redness, it might lead to a false positive interpretation. A new test which has come out after the 2018, it is called 2017-2018, it is called quantiferon testing, where the blood is tested, and the principle behind this is when there is TB bacteria in the body, it doesn't mean the bacteria is actively dividing or not. So this test is positive for both latent TB or just TB infection, or active TB, because it just needs a presence of TB bacteria in the body. So when the TB bacteria is in the body, they release certain antigens, and these antigens activate the lymphocytes in our body to release certain kind of radiation called interferon gamma radiations, which are detected by this blood test. So the important thing to remember, quantiferon positive, it just means that the patient has been exposed to TB bacteria. That means that even one or few TB bacteria have entered inside the body. They might be in sleeping stage or latent stage, or they might actually be active. We cannot really say whether it is latent TB or active TB just based on the quantiferon test. But the good thing is it is not operator dependent, it is machine dependent, and it doesn't need a follow-up visit, and it is not affected by previous BCG vaccination. So the treatment, important things to remember is we have to cure the patient. At the same time, we have to prevent the transmission. And at the same time, we have to prevent development of resistance, which is the most important, this thing, considering community aspect, it is to prevent development of resistance. So the treatment of TB, it is a multi-drug combination. We should never initiate initially just single drug for TB treatment, because it can result in rapid development of resistance, and it might result in a situation called multi-drug or extensively drug-resistant tuberculosis, which might eventually cause a great harm to the human population. And we have to remember that all the patients have to be treated for adequate doses for adequate duration. Directly, it should be a directly observed treatment, because many a times it's a prolonged treatment for almost 6 to 9 months. So the patient, the compliance for the patient to the treatment might drop down, especially with continuing treatment. So usually for active TB, we always recommend directly observed, where where a healthcare practitioner have to observe that the patient is taking the TB tablets. And patient needs adequate nutritional support and vitamin support. Comorbidities like diabetes, HIV, vitamin D deficiency have to be treated, and there is no need of any kind of stigma towards TB patients. For drug sensitive Mycobacterium tuberculosis, they are treated for 6 months. The first 2 months is intensive phase, where we give 4 TB medications, and the next 4 months is continuation or maintenance phase, where we give 2 TB treatment. So the four medicines usually used as first line, which are cheap, easily available oral option, and highly proven to be useful in sensitive tuberculosis, are isoniazid, rifampin, pyrazinamide, and ethambutol, where rifampin is usually acts as the backbone for any TB regimen. The last 4 months is isoniazid with rifampicin. The treatment must be directly observed for all cases, and this direct observation, either it can be at a health center. When the patients are admitted, every day the nurses observe that the patient is taking the tablet, or there is something that we use called CST in CDC, which is called community supervised treatment. This is usually reserved for patients who are at risk of non-compliance, or who have history of being defaulters. We send a home team to go to the patient's workplace or home and give the tablet to the patient and directly observe that the patient is taking the tablet. But for majority, we do something called video dots, where we have an application where the nurses call the patients every day whenever they are scheduled, whenever comfortable for them to make, and through video call, the patient is identified, and the dots nurse will make sure the patient is taking the medication in the right dose in the proper manner. It's called video dots. There will be follow-up with the physician physically at 2 months of treatment, 4 months of treatment, and at 6 months before stopping the treatment. So these are the drug doses and treatment guidelines. I don't think it's very relevant for today's discussion. The drug doses, usually it is discussed with the infectious diseases physician to calculate how the drugs are dosed. Usually it is based on the body weight. And there are certain categories for most of the patients who are below 54 kilograms. They are given 3 tablets of Rifa-4, which is a combination therapy with pyridoxine. And 54 to 72 kilograms, they are given 4 tablets. Above 72 kilograms, they are given 5 tablets. This is in general a basic idea. I see a hand raised by Mr. Ahmed. If you would like to ask the question now, you can go ahead. Or if you want to wait till the end of the presentation, that's also okay. Okay. I think probably that's by mistake. I'll continue. So the treatment of latent TB is when the patient is infected by the TB bacterium, which is shown by a positive quantiferon test or positive skin test, which is PPD test. So if any of these are positive, then the person has to be evaluated for any symptoms or signs or radiological features related to active TB. If we finally make sure the patient doesn't have any symptoms or signs or radiological features related to active TB, finally we conclude that the patient has a latent tuberculosis. So such people, they are at risk of developing active TB in future, which is around 10% for an immunocompetent patient, whereas for immunocompromised patient, it is much, much higher. So we have to discuss with everyone regarding their risk stratification for developing TB in the future. Immunocompromised patient, healthcare staff, or somebody who is coming from a high TB burden country to a low TB burden country are definitely required to be on prophylactic therapy for latent tuberculosis. So there are 5 different options for this. Most studied and most commonly used is daily combination therapy of isoniazid and rifampin with pyridoxine for 3 months. But there are other treatments like people who cannot tolerate 2 drug therapies. They might go for isoniazid alone for 6 months or rifampin alone for 4 months. There are newer therapies which have been developed, like for people who don't want to take tablets every day. There is rifampicin plus isoniazid, which is taken once weekly for 12 weeks, or the duration is the same. That means it is 3 months. And there is a newer therapy which is approved by WHO, which is rifampicin plus isoniazid for 1 month, which is the shortest available prophylaxis for latent tuberculosis. So, for we all know how we from infection control point of view, how to prevent tuberculosis. Basically, the patients who have suspected or active tuberculosis are put under airborne precaution, and whenever somebody goes near them, they have to make sure they wear an N95 mask and other basic hospital protocols that we follow for TB prevention. And we already have talked about BCG vaccination, which is live attenuated Mycobacterium bovis. This is BCG. So people who have this, because it's actually a mycobacterium which is attenuated to give the vaccine. So such people who have been injected with BCG vaccine, they can actually have a positive PPD test. There is a certain entity called multi-drug resistant tuberculosis, which drug resistance emerges. Especially the biggest risk factor are patients who are drug defaulters, like they take TB treatment for certain treatment or even prophylaxis, and then they stop the treatment. So there might be some bacteria which have not been cleared completely. They remain in the body and they have genetic mechanisms by which they develop resistance. So the treatment of multi-drug resistant tuberculosis is quite complicated, and it's also more expensive, and patient might have to stay in the hospital for longer duration. It might need intravenous treatment and second line treatment, which are expensive and toxic. Just to come to TB incidence rate in Qatar, actually this is the number of the green graph. It shows the number of TB cases per 100,000 population. We were able to bring it down very much till before the onset of COVID pandemic. During the COVID pandemic, because of various reasons, the incidence of TB had gone up, and now again in the last few years, this is data till 2022, the incidents have started trending down. However, the number of multi-drug resistant TB cases, it's kind of going up, especially with more and more TB treatment. And our aim is to bring down the number of multi-drug resistant TB cases. The TB deaths it's again on and off. Currently, it is trending down, the number of TB deaths. So this is all the basic information about tuberculosis. So before we finish, I have a few revision questions, just 3 questions. Anybody who would like to answer can raise their hands and answer it. I'll wait for a few seconds. If nobody interested, I'll go into the discussion of those questions. So the first question, a 29-year-old woman with a previous diagnosis of HIV and diabetes presents to a clinic with a 2-month history of cough, fevers, and night sweats, and also unintentional weight loss. She is on antiretroviral therapy. Her CD4 count is 172 and HIV viral load is undetectable. The chest X-ray shows bilateral infiltrates and several cavitary lesions in the upper lungs. The sputum microscopy reveals AFB suggestive of pulmonary TB. So the question is, what is the strongest known risk factor for the development of TB disease in this patient? Yes, so I can see, yeah, there is a question in the chats whether there is a pre-test. No, there is no pre-test. Yes, I can see a few people have answered option B, which is actually HIV. That is the right answer. Thank you for answering. This we have already discussed in the initial part. HIV is the strongest risk factor. So we'll go for the next question. We can stop answering the first question now. This is the second question. A 36-year-old man from Somalia is referred to your clinic after he was recently diagnosed with HIV. He had a tuberculin skin test performed 2 days ago at the local health department. He's not on any medications and his CD4 count and HIV RNA level are unknown to you at the time of the visit. When evaluating the tuberculin skin test 48 to 72 hours after the placement, what is the cutoff criterion to define a positive TST in a person with HIV? Yes, so you may consider answering this question now. Yeah, I think I can see few answers now. Actually, we did not discuss this area in particular because it's a quite complicated area. But what we have to remember is in people who have HIV diagnosis, in general population who have no risk of tuberculosis at all, the cutoff is 15 millimeter. But however, people who have mild risk factors like diabetes or who have recently come from an endemic country, the cutoff is 10 millimeter. But at the same time, people who have very strong risk factors like HIV or people who have a recent known exposure to a TB patient, who have a cavitary lesion in their chest X-ray, or someone who are severely immunocompromised, the cutoff is 5 millimeter. So in this patient with HIV, the cutoff for tuberculin skin test is 5 millimeter. So the answer is right as option B. Go into the last question now. Which of the following is considered a preferred treatment regimen for latent tuberculosis in persons with HIV? So this might be a little confusing. Just concentrate on all the options before answering. So you can stop answering the second question and start answering for the third question. So the options are rifampin once daily for 2 months, isoniazid plus rifampicin plus pyridoxine all weekly for 3 months, isoniazid plus rifampin plus pyridoxine all daily for 1 month, and isoniazid plus pyridoxine both daily for 3 months. So this one, I think the options are a little bit confusing. I can see people answering A, D, D, C. So I can see almost all the answers. Okay, so I can see people answering option D. I will say you why the option D is wrong, because isoniazid plus pyridoxine alone for 3 months is not an option for latent TB. Because if you are giving isoniazid alone with the vitamin, this is not with rifampicin. So one drug alone for latent TB, it should be at least for 6 months. Isoniazid alone should be for at least 6 months, sometimes up to 9 months. So this is not right, because if it would have been right if we say isoniazid plus rifampicin plus pyridoxine daily for 3 months. That is the right answer. But this option D is wrong. Regarding option C, it says isoniazid plus rifampin plus pyridoxine all daily for 1 month. No, this is not for 1 month. It is for 3 months. What is right is isoniazid plus rifapentin plus pyridoxine daily for 1 month will be a right answer. And regarding option A, rifampin alone for 2 months is not right. Rifampin alone should be for 4 months. So the last one is option B, which is isoniazid plus rifapentin plus pyridoxine. This is once weekly regimen, which is known as 3HP, which is once every week for 12 weeks or 3 months. So that's it. These are all the questions. I hope majority of the people have answered all right for all the 3 questions. And these are kind of little advanced level questions. So that reassures that there is a good understanding about tuberculosis in most of the attendees. I think we have around 600 people attending online today. So that is all with the presentation. If anybody has any question or concerns or anything, please you can go ahead with the questions. And there is a feedback form which you can access and fill in your details for the CPD points. Please, you don't have to share your corporation number in the chat. Just fill the CPD points. Sorry, fill the evaluation form for the CPD points. I'll wait for a couple of minutes just to see if there are any questions. After that, we'll finish the session. Even if we stop the session, I think the feedback form will still be available for you to fill. Yes. If you have any questions, you can switch on your mic and start speaking right away. I think that's it. So thank you everyone for attending the session. So yeah, we'll see you again. Catch up later. Thank you very much.